So, health is like money. We never have a true idea of its value until we lose it. And that probably hasn't been truer than these past 2 years as we're all trying to avoid getting sick. But the problem is healthcare is expensive. Staying healthy is expensive. Going to the doctor costs a lot of money. Health insurance costs continue to go up. The employee's portion of out-of-pocket medical expenses continue to increase year after year after year. As employers, you just can't continue to bear the weight of all those costs. So you have to pass it along in some capacity. This year in 2022, premiums are going up to pre-pandemic levels. We had a little bit of a break the past year and a half, where everything kind of was held static just based on everything that's going on. This year, the gloves are off and everything's going up. So it's been noted that they can expect somewhere between 4.7 to 5.2 increase in 2022. The average employer cost is going to go up $860. And the average employer contribution to premiums is going to go up about $62. Deductibles are continuing to rise. I couldn't find any new stats in 2022, but as of 2020, 4 in 5 workers now have a plan with a deductible. The average deductible is about $1,644 or $1,364 with some employer contributions. That could be an HRA or contributions to an HSA, perhaps. But in the past 10 years, deductibles have risen 111%. Think about that. 10 years, 111% increase. Employees cannot afford to pay. Most of them don't have the money. They don't have the financial needs to bear this burden. A recent study by the Commonwealth Fund, 37 states across the country, workers' health insurance premiums deductibles take up more than 10% of their median income. In Pennsylvania, New Jersey, we're just under 10%. Those numbers in PA is like 9.3, and New Jersey's about 9.5. So more and more of our take home is going to our healthcare. No money, more problems. 63% of Americans cannot afford an unexpected bill of $1,000 or $500, I should say. 69% of them don't even have $1,000 in savings. So if that bill comes, they don't know what they're going to do to handle it. Approximately 15% are currently going uninsured because they're worried about the cost of what care is going to take out of their pocket. 41% are paying off medical debts, and medical bills continue to be the biggest cause of bankruptcy in the United States. The other thing is employees don't understand. They do not understand their health insurance. 52% of Americans have no or little to health insurance literacy. Better than half don't know the premiums or deductibles. Co-pays they're semi-familiar with because they know they give the money up when they go for that doctor's visit. But the majority of Americans have no idea the difference between a copay, a deductible. All they know is all this stuff is costing them a lot of money and they don't understand why. On top of it, providers are losing revenue. As employees' out-of-pocket expenses continue to go up and up and up, as patients, we're struggling to pay our bills. That means the employers are not providers are not getting paid, I should say, and their cost to collect is going up and up. Right now, on average, across the United States, after all the expenses attempting to bring payment in, paper, postage, manpower, phone calls, medical providers are netting out somewhere between 20 to 40% on the dollar. So that's 20 to 40 cents on the dollar on the patient's responsibility of deductibles and coinsurance. It's a minimum of 6 months before they ever see a penny. Could be a year, could be a year and a half if they get paid at all. As hospitals are facing these higher employee responsibilities and slower reimbursements, 30% of the average healthcare bill now comes from the patient's pocket. 68% of hospital bills under $500 are not paid in full. 72% say patient financial responsibility is their biggest worry right now on the rev cycle side. 77% of patients do not pay within a month. There's a few out there, but the majority, as I mentioned, it takes a minimum of 2 statements and about 6 months before they ever render a payment. And 70% says it takes at least 30 days to try to collect on any kind of past due accounts. On top of all that, the patient experience is impacted. So the last thing a patient remembers receiving is getting that bill. They could have the best clinical care in the world, but when that bill shows up, everything goes sideways because A, they don't understand it. They don't understand the EOB. They don't understand the terminology. They don't understand what their insurance carrier is going to pay or not going to pay. All they know is I have this bill now, and now I have to figure out how I'm going to take care of it. 30% of those surveyed said that the decrease in satisfaction just occurs between discharge and billing. 65% consider switching providers for a better billing experience. So they want a better billing experience. They want to be able to understand and have it clear for them. 71% want to pay bills all in one place. And going back to what we talked about on the insurance literacy, 74% are confused by their EOBs and medical bills. 88% want customized payment plans. And we may start seeing a little bit of this as the price transparency continues to unfold. We'll see what that brings out. That should help a little bit, but it's not going to take care of everything. So how are employers attempting to control expenses and address this cost shift? Well, we already talked about high deductible health plans. Introducing high deductible health plans, certainly is helping on the employer side, but again, the employees are having to deal with those higher out-of-pocket expenses. Some are instituting an HRA. It helps reduce that employer burden, but it's not saving the employer anything. Introducing some sort of health payment plans, maybe an HSA or an FSA, perhaps making even contributions to the employee's account to try to reduce some of their out-of-pocket burden. But again, it's still on the employer for the most part. You can, try negotiating your benefits, switching plans, changing brokers, but most of you have been there, you've done that. It's not a fun process either. And to try to do that every year, go back and forth, it gets a little labor intensive and it's very time consuming. And then you can introduce some supplemental insurance plan, gap plans, AFLAC, but again, they all have a cost associated with them. Wellness programs, yeah, they help. They help maybe reduce the cost of the insurance in the long run, but again, they require time, they require buy-in from leadership, and then of course the employees still have to take hold of the program and work with it and go with it. Same kind of idea as far as employee incentive. You can offer third-party programs. You can, try to educate them on their benefits and making sure they're making the right decisions for themselves and their families. And you can try to make sure that they're making the right health decisions as far as their care, using teledoc visits versus going in person, or not going to the ER, or not going to an urgent care when you can go to a primary, whatever that situation may be. So how are we addressing the problem as AblePay? And what is AblePay? So we're a unique revenue cycle model that we're helping providers minimize those expenses as far as collecting from their patients. We're providing the providers prompt payment in 14 days on behalf of our members. In exchange, they're willing to accept a lower amount as payment in full because now they don't have all those expenses to deal with, and they're guaranteed that payment so they don't have to worry about collecting from the employee or the patient as far as their responsibility is concerned. Most recently, we now have a collaboration with Independence Blue Cross and AmeriHealth New Jersey. They're introducing AblePay to all of their members at this point. That started at the end of December. So You may see something personally if you have Independence Blue Cross or AmeriHealth New Jersey as your carrier. You may, even see something at your place of employment. We have some of their brokers working with small groups, going out and talking to employers as well about Able Pay. But they saw the value of what we're doing and how it's going to be able to benefit their members in the long run. So what is Able Pay? It's a no-cost program. And that's inevitably the first question we always get. It says it right here on the front of the brochure, it's no cost, but everybody wants to know how we can do that. I just mentioned, the providers are collecting on average maybe 20 to 40 cents on the dollar. We're going to give them double or maybe more than double what they're collecting on average right now, and we're going to pay them promptly in 14 days. So they're willing to accept that lower amount as payment in full. That's how we fund our business. That's how we are able to pass along savings to our members. So it doesn't cost our members anything. It does not cost you as an employer anything to offer the program. And there's no recourse going back on you as an employer. If John Smith enrolls through your company, if you introduce it and decides he doesn't want to pay his bill through Able Pay, it's not like we're picking up the phone and calling ABC company and said, hey, John Smith didn't pay their bill this month. What are we going to do about it? The membership is between the employee and Able Pay. It's theirs to use as long as they want to use it. They can, as long as they have a primary health insurance in place, including Medicare, they can keep that Able Pay membership valid and continue to save money on their bills. But there's 4 major benefits that we're going to provide to you or your employees: savings, flexibility, and convenience. These 3 are going to work hand in hand as far as how somebody pays their bills through Able Pay. And then our advocacy program has become a bigger and bigger part of what we're doing every day, much bigger than we ever anticipated when we started this business. So anytime one of our members has a question, something doesn't appear right, or there's a discrepancy on the bill, the EOB says one thing, the bill says something else, all they have to do is call us. If it's a billing discrepancy and we're not able to answer that question immediately, we'll start making phone calls to the provider's billing office on behalf of our member so they don't have to spend 2 hours of their day trying to get answers. We're going to do all that for them on the back end. Down below here where it says payment terms and savings, these are the option that a member has on every bill we process for them. So the first—
Hey, Rick, we're not seeing the brochure, just so you know.
You're not?
No.
Okay, sorry about that. Let's see here. How about no?
Yep, we did see it there for a second.
Now?
Yes.
Okay. Thank you. So down below here where it says payment terms and savings, you'll see the first thing is one says bank and one says card. So when a member enrolls, they're going to link some sort of payment method with their account. Anything that has an account and a routing number, checking, savings, health savings account, providing they have the account and the routing number, will go in as ACH. Anything that's card driven, credit, debit, flexible spending accounts. Sometimes in HSA, we've encountered a few for whatever reason, they can't get the account or the routing number, goes in as a card. We get charged a higher fee for processing card payments than we do bank transactions. Hence, the savings are going to be a little bit lower if you decide to pay with a card versus the ACH. But you'll see if a member has the ability to pay in one payment, they're going to be able to realize the highest savings, but they have the flexibility to decide on every bill what works for them financially. So if they need a little bit more time, they can spread that out over 3 or 6 payments, still realize some savings. Larger bill, they need more time, they can spread it out over 12 payments. There's no savings at 12, but we don't charge them any interest. So we become a free financing vehicle for them at that point. I'm going to attempt to walk you through the enrollment process here. Hopefully everything's going to work. Kevin, we good? You can see the screen now?
Yes, we can. Yep.
Okay. So very quickly, if you're interested in introducing Able Pay to your team, It's a simple process. Just let us know. We can do a webinar such as we're doing right now, educate everybody on it. We can provide you some emails to send out, some videos to send out, a link to the enrollment. It all points back to this same enrollment. So there's a brief welcome. We ask them a few questions about their current billing experience. The slide earlier mentioned about changing the patient experience. We are doing that. Our members give us a score based on their satisfaction levels with their current billing experiences without able pay. And last survey we did, we've increased these satisfaction levels by 64%. But ultimately, we are changing that experience for the patient as well. So someone becomes the main account holder. In our example here, it's Mary Smith. So when Mary enrolls, she just gives us her basic demographic information, where she resides, how we get in touch with her, and where she's employed. We ask the employment question for a couple reasons. We assume all the risk. We're paying the provider in 14 days, regardless if a member pays us in one payment or 12 payments. So we're hoping who's ever enrolling is gainfully employed or going to be able to pay their bills through able pay. The other thing is anybody with a primary health insurance can take advantage of the program. They don't have to come through an employer. So someone coming in off the street, what we deem an individual, we're going to do a soft inquiry, does not impact their credit score. Again, it's a risk assessment for us. But if you introduce it to your team and to your employees, everybody there, full-time, part-time, if they have benefits with you or not, they are all in, no questions asked. So all they have to do is indicate, I work at XYZ company. We know they're part of that relationship and they're all in automatically. They can then add anybody on their able pay account they're willing to be financially responsible for. They do not have to be a dependent. They do not have to have the same health insurance. So if, for an example, you have somebody that works for you and maybe gets benefits through your company, and you have independents as an example, and their spouse works someplace else and they have Highmark, two different insurance carriers, it doesn't matter. They all go on the same able pay account. And because everything we're going to do happens after that primary insurance process. So Mary has her spouse, she has her two children, she has her mother-in-law on the account. She's helping her mother-in-law keep track of her bills. So when you're done adding members, I mentioned we have that collaboration with Independence and AmeriHealth New Jersey right now. So we've begun collecting this data for them. If it's applicable, someone can indicate their Independence Blue number, et cetera, as far as their insurance is concerned. If it's not applicable, they just skip right over it. Then they select a default payment term. This mimics what I showed you in the brochure previously. Our members will always have 5 days to decide which one of these options, 1, 3, 6, or 12, make the most sense for them financially. If they make no changes in that 5-day window, whatever they've selected as that default payment term and whatever they put in as their primary payment method, that's what we're going to use to satisfy the claim. So in our example, Mary wants to save the most amount of money, so we'll leave it at 1. She's then going to add at least one payment method. She can have as many as she wants. So in our example, she has her checking account. That's the primary. That's the little check mark here. She has her Visa card or MasterCard in here, and then she has her HSA account. For whatever reason, she couldn't get the account or routing number, so that went into as a card as well. We do not maintain anyone's financials. As soon as it's entered at this stage, banking information goes to a company called PayStand. Card information goes to a company called Stripe. They're both PCI Level 1 secure financial warehouses. So all we ever see is a token or the last couple of digits of the account. And then finally, they'll review the terms of service, the privacy policy, sign off. I won't go over all that. Everything we do is HIPAA compliant, so we're never going to sell anyone's information. We're not going to share their information. All we're going to do with it is what we have to on their behalf to help them get answers or settle that claim. And then the final step, email is our main mode of communication. So we try to ensure that the email address that someone is enrolling with is legitimate, that we can communicate with them, and we'll send out a code to do that. We do not hold up anybody's enrollment. If they don't get the code, they can still enroll. We'll verify it after the fact. Let's assume Mary got the code. That's how quick and simple it is to enroll. It's a 5-minute process. What happens next? Once your account's set up, we're going to send your Able Pay health cards to you in the mail. They look very much like your primary health insurance card. The member's name and everybody that you put on your account will get a card with their name on it, your unique Able Pay ID, and our information's on the back. The next time you go to the doctor, you go to the hospital, you're going to verify or show your primary health insurance, and then you're going to show Able Pay. Able Pay gets entered as a secondary payer. We're not insurance, but we go in as the secondary. If there is secondary, we'd go in as tertiary. The majority of folks put us in as secondary. So you're going to generate a charge. That bill's going to go out to the primary first. They're going to adjudicate the bill. They're going to pay the provider whatever their agreement is. As a member, you still receive your explanation of benefits. That doesn't change. The only difference, instead of getting that bill in the mail from the provider for what you owe, that comes to Able Pay electronically. We send you the email. You have a new bill. Go to your member portal. Tell us how you want to handle it. So the portal looks exactly like this. There's a lot of informational buttons scattered throughout. So we've tried to be very proactive as far as providing the information, but it'll tell the member when their membership began, how much money they saved, if they have a credit balance, because every member has a unique referral link that they can refer friends and families and neighbors and get some credit for helping spread the word. But the majority of the time is going to be spent here in claims. So all your bills are going to be stored electronically here in the portal. So when Mary enrolled, she selected the term of 1 to get the highest savings, and she put in her bank account as the primary payment method. This is Mary's default. That's why it's showing up in there. Again, Mary's always going to have 5 days to decide if she wants to make a change. So in our first example, Mary has a bill for $50. She doesn't recall what this bill's for. She can just hit the view. It's going to open up a new window. It's going to tell her who the provider was, who the patient was, the date of service, what the charges were, what the insurance paid, all the way down to the savings she's eventually going to realize. In this example, it's a copay bill for $50. So as long as Mary has the ability to pay in one payment and wants to leave it on her checking account, she's going to save the full 13%. We're going to pull $43.50 from her authorized payment method. $50 is now satisfied at the provider. Mary just saved $6.50. That's how Able Pay works. That's how simple it is. But we talked about the flexibility. So in our second example, John's got a bill from the hospital for $1,020. Again, if they want and they want to leave it on the bank account and pay in one payment, they certainly can do that and save $132. But let's assume they want to maybe put it on the HSA card this time. There's money in there. They want to use it up. You'll see the discount changed from 13 to 10%. So if they have the ability to pay in one payment, we're going to charge the card $918.31. $1,020.34 goes against the deductible. The whole $1,020.34 is satisfied at the provider. John and Mary just saved $102.03. Or maybe they want to leave it on the checking account, but they don't have the ability to pay in one payment. So they have the flexibility to decide if they want to span it out. So you'll see as I toggle through, the discount changed. So again, in this scenario, they're still going to save 10%. They'll save $102, but now we just broke it into 3 manageable payments at $306.11. So today's February 8th. Once they would confirm that payment change, we'd pull that first payment today. And then right around the 8th of the next 2 months, we'd pull those subsequent payments of $306. And we do notify our members about a week prior, anytime that we're going to pull or charge, just to make sure there's enough money in the account, etc. So that's the mechanics of Able Pay. I know we're getting short on time. So very quickly, I'll just show you. We have a message center here. A member can send us a text message. Obviously, they can upload a bill. So if a member would ever get a bill at home, that means we did not receive it. we tell them, don't worry about it, don't pay it, just send a copy. So if they can scan it, they can upload it right here on their portal. They can simply take a clean image with their smartphone and upload it that way. They can email it to us, they can fax this to us, whatever works. All they have to do is get a copy over to us. And then finally, here's a list of all the providers currently accepting Able Pay. So St. Luke's University Health Network, Lehigh Valley Health Network, Mainline Health System, Penn Medicine, not only in Philadelphia, but Princeton and Lancaster General, Grandview Health, and we're adding and having conversations with providers all the time. We started here in Bethlehem, Pennsylvania. We've been doing this for the last 4 years. Currently, we are now also in the state of Ohio. We are in Indiana. We're in Kentucky. We're in Georgia. We may be in Florida sooner rather than later. And we have a number of other providers in various states, not only in Pennsylvania, New Jersey, in the pipeline that we're having conversation with.
Rick, that's great. I got to cut you off here. One question came in. Does this cover dental and vision as well?
It does not. So it's only on medical claims. So we look at dental, vision, and prescriptions as ancillary insurance products. The payment structures are totally different between all three of them, and they're completely different than what we're dealing with on the medical side. So we are looking at some options, but right now it's strictly on medical.
Okay. A couple questions came in that maybe you can address by chat directly since we're running a little bit late here. I think, we had a meeting the other week about well-being and nutrition. I think Able Pay is another example. This may not be for every employee. Some people might have different ways they're making payments. Some people don't, just want to write a check. But, the idea, again, of we're not all the same and offering something that's, again, doesn't cost an employer anything, but that some segment of your employee base, maybe 5, maybe 15, maybe 30% would find very valuable and cost effective, I think is why programs like this are very interesting to take a look at, with the way they've structured this. It is very easy to use. We actually have offered it to the MEA employees, and some are taking full advantage of it. So if you want to learn more, just you can reach out to us and we can put you in contact directly with Rick. But again, thank you, Rick. That was a great explanation. And again, it's kind of this, you're in a factoring space, which is kind of very common. It's just different in the healthcare space.